Super important and critical topic that drives me crazy, that students, residents, everybody seems to get mixed up in their minds. And that's DVT prophylaxis versus anticoagulation. And my little board here literally has a line in the middle of it, and that's how much I want to separate out these two things. So we're going to put over here DVT prophylaxis, okay? And over on the complete opposite side, we're going to talk about anticoagulation. These are two completely different things. Everybody that comes into the hospital, for the most part, gets put on not only mechanical DVT prophylaxis with SCDs, or sequential compression devices, put on their legs to squeeze their legs because they're stuck in bed, and we want our physical therapists and our occupational therapists, we get them up out of bed as much as possible, extremely important. But to protect our patients against deep vein thromboses, everybody in the hospital, for the most part, we'll talk about some reasons not to be, is on chemical DVT prophylaxis. And the thing we use most often is called Lovenox. Lovenox is low molecular weight heparin, okay? If you're a regular old patient in the hospital, you're going to get subcutaneous into the tissues, just a shot, if you will, Lovenox 40 milligrams every day, once a day. That's for your regular old hospital patient. If you are a trauma patient, we are even more aggressive with the dose that we give to our patients of Lovenox. They get 30 BID every 12 hours, okay? That is the trauma dose for chemical DVT prophylaxis with Lovenox, 30 BID of Lovenox, okay? Now, if they have renal insufficiency, we switch to regular old subcutaneous heparin, and we give 5,000 units every 8 hours, okay? So renal insufficiency, you can't use Lovenox, you got to use subcutaneous heparin. So who doesn't get DVT prophylaxis? Well, patients with spinal cord injuries, like a spinal epidural hematoma, bleeding around the spinal cord, bleeding in the brain. And we follow what's called the Parkland formula, or modification or criteria for DVT prophylaxis in brain injured patients. I will talk to you guys about that another day because that's its own lecture. Versus anticoagulation, two totally different concepts. Patients that are anticoagulated have a DVT, okay? They have a deep vein thrombosis, okay? They have atrial fibrillation. A DVT can cause a PE, a pulmonary embolus. Full anticoagulation is not the same as subcutaneous heparin. You would be on IV heparin or intravenous heparin, or what we would call a heparin drip. And then to monitor that, you have to monitor your PTT, okay? That's the lab for your coagulation profile. Partial thromboplastin time is your PTT. And I always say therapeutic is like 60 to 90. That's where I like this to be. And then in today's world, in the olden days, we used to use warfarin or Coumadin. Vitamin K epoxide reductase inhibitor is how that works. The vitamin K dependent coagulation factors are 2, 7, 9, 10, never going to clot again. That's how I remember it. So that's how warfarin works, more old school. But again, you guys have heard me talk about then DOACs, right? Or the direct oral anticoagulants, which are mostly our 10A inhibitors, which is Xarelto, Eliquis. Those are the more novel. They used to be called NOACs, now they're called DOACs. This is literally a completely different topic than this. Please understand that. It drives me crazy.